Now, when we're talking about hypertension, this I think is in what chapter in your book? 38, 7, 6. What did I put? It's one of those, okay? And it's just really kind of a part of a chapter. But you guys are going to be running into so many people in your practice that have hypertension. 65 million people in the United States alone have been diagnosed with hypertension. Okay, that's about 1 in 3 people will end up having hypertension in their lifetime. It is known as a silent killer in that we do not really have any signs and symptoms of hypertension until you start to have organ damage. 30% of the population out there with hypertension do not even know that they have it. And only about 34% of the people who know they have it actually have it under control. And we're going to talk about what happens when you don't keep it under control. There's a higher risk of hypertension developing in African Americans, especially African American males. Now, when we start talking about gender risk, men usually have it more than women at a younger age. But as we age, women tend to develop it at a faster rate than the males do. So girls, we can look forward to that later in life if we don't already have it. On top of everything, dropping, sagging, falling out, yes, absolutely, yes. Hypertension is responsible for about 62% of strokes out there, and about half of the people who have ischemic heart disease also have high blood pressure. About half have ischemic heart disease. I'm not going to ask you to quote them numbers back at me. Okay, so you're okay with that. I just want you to see how prevalent it is and who's going to be getting it around, early life, late life, that kind of thing. Okay, who's more at risk? Because that's one of those things that when you're doing your assessment, you're asking about history, hypertension, all those chronic issues that we've started to talk about this semester. Okay. Now, when we are defining hypertension, your normal blood pressure is what? Less than 120 over 80. Right? You remember that? Please tell me you do from 102. I hope you brought that forward. Okay? Systolic, we really want less than 120. Diastolic, less than 80. And Iggy talks about some pre-hypertension. In my day, anything 120, over 120 was considered hypertension. Okay, they've dropped that now. Now we're starting to look at pre-hypertension states, and those are your numbers right there. I'm not going to ask you those either, but just know that now they've started to look at hypertension and treat it earlier than they used to. And that's so that we don't get all this organ damage and complications that come from hypertension. There's also stage 1 and stage 2 and all that business. You're not diagnosing it, right? But you do need to know when to be concerned, and we'll talk about that. So really, we're going to start defining hypertension and high blood pressure as a blood pressure that is greater than or equal to 140 over 90. Okay? That person is said to be hypertensive. And this diagnosis is awarded when you have 2 or more accurate readings taken during 2 or more visits with a healthcare provider. Okay? Somebody that knows what they're doing, not the tunnel thing you stick your arm in at Walmart. Okay? Because you'll have people come to you freaking out because that thing has read high. Okay? So it has to be 2 or more readings by somebody who knows what they're doing, or somebody that you can rely on, or equipment that has been calibrated and that kind of thing. Okay, we can't always say that about some of these outlying places. Now, I would hope that your clinics and things like that, your medical facilities, have got the appropriate equipment. So tell me, what actually is blood pressure? What is it? Huh? The force of the blood as it is pumped by the heart against the arterial walls. Okay, so it's the force of blood flow. Arterial blood flow. The highest peak of pressure when the ventricles contract is your systolic pressure. The lowest point when your ventricles are relaxed is your diastolic. Normally there's about a 40 millimeter of mercury difference in those. Not always, but normally it's a difference of about 40. Now, your book talks about types of hypertension. Primary hypertension is also called essential hypertension. And this is about 90 to 95% of the hypertension that you're going to see out there. There's really no known cause for it. It just is there. And what they're, really think that it's an issue between all those forces in your body that control blood pressure, which we'll talk about in a minute. But that byplay, something is not working just exactly right. Okay? So they think that that's why people just develop hypertension. Primary hypertension. No cause for it, it's just there. Okay. Essential. Mm-hmm. So, secondary hypertension is your patient has hypertension because of some other condition. It is secondary to something. All right. We'll talk about those issues as well. Now let's go back just a little bit about A&P. I know that y'all have been talking cardiac issues the last several days. But let's go back and kind of refresh our memories about that process for regulation of blood pressure. Okay? Blood pressure is really the cardiac output times the peripheral vascular resistance. Okay? So I want you to start understanding these concepts, because as you move on and you get more and more into cardiac, you're going to learn more about how these things are affecting other disease conditions out there. Okay, so start to lay these tracks down in your mind. Cardiac output, peripheral vascular resistance. So what is your cardiac output? What is that? It's your heart rate times your stroke volume. It's how much blood is put out, okay, by the heart. cardiac output. Who'd have thought? Okay. So it's the volume of blood that's pumped by the heart, usually over about a minute. Okay, it's a time frame there, and it's usually a minute. And your cardiac output is really based on the strength of the contraction of the left ventricle, the rate and rhythm of the heart. Okay. So the other thing that helps to determine your blood pressure is peripheral vascular resistance. This is how much force that is in the blood vessels that the left ventricle has to overcome. The force to eject the blood from the heart. Okay? It's the resistance to blood flow, and it's based on several different things. Your systemic vascular, peripheral vascular resistance changes. Okay, it's really determined by the diameter of your blood vessels. So the more open they are, the less resistance you have, right? It's also determined by how thick your blood is. And it's also determined by the length of your blood vessels. So diameter and length, so the longer your vessels are, the harder the heart has to push to perfuse all the way to the end. So in order for hypertension to occur, there has to be a change to one or more of those factors. Either the heart rate, the stroke volume, the force of contraction, the diameter of the blood vessels, and fluid volume. Okay. So you got to have a change to one of those factors or some kind of mess up in your regulatory system. Okay. So there's a lot of factors that come into play there. Got it? So our regulatory system for our blood pressure is the sympathetic nervous system. Stimulation of the sympathetic nervous system, remember, that's your fight or flight business. Okay? So what happens is the sympathetic nervous system pushes out catecholamines, norepinephrine, and epinephrine. And these are vasoconstrictors. So norepinephrine constricts the blood vessels. To increase your peripheral vascular resistance. Okay. And raise your blood pressure, getting you ready for that extra boost that you might need. And then epinephrine does the same thing, but epinephrine also affects the heart rate. Okay, so it's a vasoconstrictor too, but it also will increase the heart rate and increases the force of contraction from the heart. So remember when you were learning about that fight or flight business? What happens to the blood flow? How does the body shunt the blood flow? It goes to those major organs, right? The lungs, the brain, and it shunts it away from the kidneys. So what does the kidneys do as a result? They start releasing renin, which helps to release all that angiotensin and angiotensin 2 and all that yada, yada, yada that helps to retain fluid, to increase blood pressure as well. Okay. It's a pretty involved process, huh? So once you get another reason is I want you to kind of understand the process, because the drugs you're going to be given are going to work at different points in that process. Okay, whether it's working up toward the kidneys and angiotensin or blocking beta blockers and all that stuff. So just an understanding of how it works. So angiotensin stimulates the adrenal cortex to secrete aldosterone. Remember that hormone? That helps you to retain sodium and retain water. Again, it's helping to regulate it. So when we have this going kind of crazy, that contributes to your hypertension, or contributes to the development of hypertension. Now, just like we were talking about earlier, age affects everything. Age-related changes also affect your blood pressure. Okay. After the age of 60, the peripheral vascular resistance starts to increase by about 1% every year. That has to do with some atherosclerosis. You've got people who, not watched their diet for 60 years. They've eaten lard and everything else they can get their hands on. That's not so much an issue now, but it is with your elderly population, your 70 and 80-year-olds who grew up on the farm, and that's what they ate. So you don't see a whole lot of that in your younger folks anymore. But we still get our atherosclerotic changes from our French fries and our tater chips and all those fun things. Okay. So research shows that older people do benefit from controlling their hypertension at any age. So used to, if somebody was in their 80s, they didn't put them on a whole lot of blood pressure medications because they were in their 80s. But they still benefit from being put on those medications and those lifestyle changes and things like that. So they don't use age as a factor anymore when trying to determine treatment. So there's no really barrier to aggressive treatment based on age. Atherosclerotic changes reduce the elasticity of the arteries. They make them narrower, not the diameter's narrow, and it also decreases the cardiac output and increases your peripheral vascular resistance. So that's just hypertension in a nutshell, right? Of the arteries. That's okay. We'll say that's the same thing. You also have some changes to your pulse pressure, which we said is the difference between the systolic and diastolic. that pressure widens. That's why you may see, that's because the arteries are not as elastic anymore. So what happens is you start seeing people who have blood pressures of 150 over, 60, much wider pulse pressures, and you'll see that as people age. Okay? Bless you. Questions about that? That's a lot to throw at you at 8 o'clock in the morning, huh? I've never wanted to know about renin and angiotensin at 8 o'clock in the morning. All right, let's talk about primary or essential hypertension. Remember, this is the bulk of what you're going to be seeing in your population. A lot of risk factors out there, and this is some of them. Dyslipidemia means they have elevated lipid levels, and we just talked about atherosclerosis, right? Where does those elevated lipid levels, where does that settle out in your bloodstream? Atherosclerosis, diabetes. Patients with diabetes have a much higher risk of developing hypertension. It's because the diabetes damages your blood cells. I'm sorry, not your cells, your blood vessels. I'm sorry. Whew. Could be. Yeah, sure could be. Damage your blood vessels. I'm sorry. Not cells, blood vessels. Okay. Tobacco use. Why in the world would smoking cause you to have hypertension? Right, the nicotine is a powerful vasoconstrictor. Age we talked about. Family history. It is thought that there is some genetic predisposition to hypertension. So we want to ask, now we're talking immediate family. Okay. Sedentary lifestyle. And then obesity. So if you're elderly, you don't move, you're fat and you smoke, you got some issues going on there. Okay. Got some issues. Or got some big risks going on. Okay. Other risk factors that may contribute, can you think of any? Can you think of anything other than those right there? Stress, wow. That'll do it. That'll do it. Stress will do it. Some types of medications, such as oral contraceptives, can cause elevated blood pressure. Caffeine, amphetamines, cocaine. And then, of course, we've already said that race can play a part in this. Now, usually your... Hello. We broke it. Hold on. Well, we might as well go home. Going on. Okay. So when we're talking about, remember we said that hypertension, primary hypertension is usually a silent disease. Asymptomatic. Your patient may present with very vague symptoms, right? But when they do start to have symptoms, it's usually either because their blood pressure is just sky high, or because they have started to have some organ compromise. The blood pressure has started to damage the blood vessels in the heart, or the brain, the eyes, the kidneys, and your patient will have signs and symptoms of problems there, okay? Your patient may just present with a headache. It's usually occipital in nature. Where's occipital? In the back of the head, good. Low back of the head. They may be dizzy, lightheaded, or they may have a nosebleed. I've seen folks come in with no history of hypertension, and they just have a sudden big old nosebleed, and when you start taking their blood pressure, it's 180 over 100. You know, never had any problems before, or that they knew of. So that may be the way that your patient presents. It's just with a nosebleed. So when we're talking about issues with organ damage, this is kind of in a nutshell what happens. Now, I have this posted separately on your course shelf with your lecture notes. I posted it yesterday. So it's kind of hard to see this on the screen, but you have a copy of it if you're so inclined to take a look at it. But what happens is, these are your four main issues, or your four main organ systems that are going to be affected by high blood pressure and uncontrolled high blood pressure. Your heart, your kidneys, the brain, and your eyes. Because what's going to happen, it's going to be those smaller arteries that are going to be damaged first. And where are the smallest arteries in your body? In those four areas. Okay? We'll talk about these four areas again next Wednesday when we hit diabetes. Okay? So when we're talking about those complications with the heart, coronary artery disease reduces the blood supply to what? You have coronary artery disease, the blood supply is reduced to what? The heart itself. Absolutely, to the heart itself. So when you have decreased blood flow and oxygenation to the cardiac muscle, what happens? It dies, it starts cramping and acting goofy, and you have chest pain that can proceed to a myocardial infarction. And or congestive heart failure. So coronary artery disease will develop in your patients that have hypertension 2 to 3 times more often than a person who has normal blood pressure. And high blood pressure precedes congestive heart failure about 90% of the time. So we really need to be monitoring our patients that have been diagnosed with hypertension. We're monitoring them for cardiac compromise, development of congestive heart failure, development of coronary artery disease. But again, 90% of your patients are going to develop congestive heart failure. Why? Why? Why does hypertension predispose a person to congestive heart failure? The heart's pumping faster, and what else is getting bigger and working harder? The left ventricle. The left ventricle is having to work harder to try to maintain that cardiac output. Good. Now, kidney complications. Remember, we talked about blood flow and Blood pressure, the kidneys are affected easily by changes in blood pressure. So what you're going to see, initial indicators of renal problems and renal failure in these patients are nocturia, which is what? Needing to go to the bathroom at night. And also azotemia. And azotemia is the accumulation of nitrogen waste in the body and in the blood. azotemia, azotemia. It's accumulation of nitrogen waste products in the blood and in the body. So what actually happens is your renal arteries actually start to narrow. And so they decrease the renal blood flow, decreasing the renal function and progression to chronic renal failure. You're going to see protein in the blood. No, I'm sorry. Protein in the urine and blood may be seen in the urine. I have some dyslexia or something this morning. So how do I know I'm getting into issues with my kidneys? Decreased urine output. What else? Higher concentration. What else? When you say higher concentration, what do you mean by that? Maybe darker, just more concentrated, right? But how are you going to know it before it gets to that point? Any kind of testing you might look at? BUN and creatinine. Exactly. Okay. Those are going to start to be affected before you start to actually have more concentrated in your. That's a later sign. Okay, so these folks with hypertension, they're getting all sorts of blood work because you're monitoring for those changes. Okay, so elevated BUN and creatinine is probably one of your first signs, along with they're needing to go to the bathroom more because they're retaining fluid, and so they're trying to get rid of it. Okay, they don't get into the retention quite yet. Eventually they do if you don't get it under control. Okay, when we're talking about the brain, prolonged hypertension constricts and damages the cerebral arteries and puts patients at risk for TIAs and CVAs. You know what those are? TIAs are the transient ischemic attacks, where you have the short-term neurological deficits. They resolve spontaneously. And then a CVA is your stroke, cerebrovascular accident. Okay, strokes. People with hypertension have a 7 times greater incidence of stroke than those with normal blood pressure. Stroke is not going to be one of the things we're going to cover in this course, but you will see it. 202 or 203, I can't remember. But you'll see it. You'll see it. With your eyes, damage to the eyes can include narrowing of the retinal arterioles. And what you see are retinal hemorrhages when you look into the eye. And you also may see papilledema. Now, this is not something that you see on the outside. This is with an eye exam, with an ophthalmoscope. Okay, but papilledema, Papil, edema, papilledema is narrowing and swelling of the optic disc. Okay. So this can lead to blindness in your patient. So we got to be monitoring for sure the heart, kidneys, brain, eyes in any patient who has hypertension. We've got to monitor for problems and hopefully avoid complications. Okay? So how do we diagnose it? We'll take a break in just a minute, guys. I know you're starting to get restless. Again, we're diagnosing it by 2 or more confirmed readings by a healthcare provider that it's greater than what? 140/90, okay? We may actually have our patients wear ambulatory blood pressure monitors to see what their blood pressure is doing over a span of time. Okay. We want to collect data about their lifestyle and other risk factors that they have. We'll talk about those later on. We may do an EKG to see about heart function. Of course, we're going to do blood studies. We're going to look at their glucose. We're going to look at their hematocrit. I want to know about their electrolytes, especially their potassium, their calcium. I want to know about their BUN and creatinine. And I'm probably going to do a lipid profile, which tells me about their cholesterol, their triglycerides. I'm definitely going to do a urinalysis, looking for protein, looking for blood. I may also do some renal studies, like renal x-rays, IVP, arteriograms, you know, those type of things. I may do cardiac stress tests. And I'm for sure going to do a chest x-ray, because I'm looking for cardiac compromise, cardiac enlargement. Okay? I'm looking for congestive heart failure. Looking for those types of things. Any questions about that? All right, let's take a break. Let's move on and talk now about medical treatment for hypertension. For hypertension, we have to make our patients understand that our goal is lifelong control of their hypertension. We're wanting to decrease the cardiovascular and renal morbidity and mortality issues, okay, by decreasing peripheral vascular resistance and decreasing their blood pressure. So our goal is to get them to do this for the rest of their life. How easy you think that is? It's a struggle. It is a struggle. Okay. Well, I don't know that you want to be that blunt. Some people, you have to be that blunt. But, you know, what do we do? We educate our patients on the risks, the benefits, okay, alternative therapies. You know, the physician does this, but we're adding to that, right? The physician's responsibility is the treatment plan. Our responsibility is to aid that plan and make sure that our patients understand. Okay, so our target is to get their blood pressure below 140/90. But if our patient already has diabetes or renal disease, we're going to shoot for lower than that. We want it to be below 130/80. Below 140/90 is our target. We just want to get them back down into normal levels. But we want to shoot lower if our patient already has diabetes or renal problems. (130/80), below 130/80. So what we want to try first is lifestyle modifications. How easy you think these are? If you got a patient that's in their 60s, or even me who just started their 50s, it's not going to be that easy. Okay. By the weight reduction can reduce blood pressure because it reduces the workload of the heart. Okay. Stopping smoking actually decreases the vasoconstriction from nicotine. When we reduce sodium, it reduces water retention and decreases blood volume. Alcohol restriction, really we want them to have less than 2 ounces a day. Yeah. Yes, I understand that completely. Yeah, about, yeah. Yeah, that's not much. That's not much. No, Chancellor, unfortunately, it doesn't work that way. It doesn't work that way. I have low blood pressure. I need to start smoking and drinking. Yeah. No, it doesn't really work that way. Exercise. A planned program of exercise improves their cardiac efficiency because it increases their cardiac output and decreases the peripheral vascular resistance. Sure. It improves their cardiac efficiency because what it does, it increases their cardiac output and it decreases peripheral vascular resistance. And this is a planned program, I need to say it again? You got it? Okay. It improves their cardiac efficiency. It increases cardiac output, decreases peripheral vascular resistance. Relaxation techniques. Okay. Meditation. Trying to do those stress relievers. And alcohol is not a stress reliever. Okay. So meditation, yoga, those types of relaxation techniques and therapies can be beneficial. Okay. So we're going to try these kind of things first. This is our first therapy. We try to get our patients to do this. If we have not been successful in lowering their blood pressure after 3 to 6 months, okay, then we're going to go to medication therapy. Okay. Now, if our patient's blood pressure is already extremely elevated, I mean like greater than 160/100, if it's at that level or above, we're going to go ahead and start our patient on drug therapy. We're not going to just wait 3 to 6 months to see if they lose some weight. Okay. We'll go ahead and start the medication first. Now, Iggy has a chart on page 781 that talks about all of these medications. Okay. I would take a look at that. Our goal with pharmacology therapy on these patients is to give the lowest dose, the fewest meds, once a day. That's our goal. We can't always do that. Okay? In fact, a lot of these patients are on combinations of these medications. Okay. How many of you know somebody who's taken or are taking hypertensive medications? How many know somebody who's taking more than one medication? See, it's about the same amount of hands, really. Okay, so most of your folks do end up being on 2 or more medications. So let's talk about these. Nope, not there. Let's talk about these. The first drug of choice, or the first class of drugs of choice, is going to be your diuretics. Remember, you've got some extra fluid in there. We want to try to decrease the blood volume and get that under control. So we're going to start with diuretics. We start with thiazide types. That's our first line. And we're talking something like HCTZ, hydrochlorothiazide. Getting there. Okay? So it's a thiazide type. That's going to be our first line. Now, there are other kinds like your loop diuretics, which is what's your main example of that? Lasix. That takes your potassium, right? Okay. And then there's also your potassium-sparing diuretics. Right? That's like your aldactone. Okay. So when you've got patients on diuretics, we have to monitor for what kind of imbalances. Fluid and electrolytes, right. Especially your potassium. Your older adults we may need to replenish potassium. So we give them something and then we got to fix what we give them, okay, based on what we give them. So your diuretics, we're going to give those in the morning to try to avoid your patients having to get up at night. We want to do daily weights on these folks. And again, we got to monitor their electrolytes. And the third one was aldactone. Mm-hmm. So your thiazides and your loops, really, they can deplete your potassium, but your aldactone does not, or it spares it. Okay. The next one on the list are beta-adrenergic receptor blockers. We also call those beta blockers. What these do are they block the release of catecholamines. And what did I tell you catecholamines do? They vasoconstrict. Remember epinephrine, norepinephrine, they constrict. Okay? These are your LOLs. They end in OLOL. Atenolol, labetalol. Okay? They block catecholamines. They also decrease the heart rate. They decrease the strength of contraction. If you think about it, if you've got somebody with hypertension, that's 3 good benefits right there from those medications. Right? You have to be careful, though. They also can lead to bronchial constriction. We're watching for bradycardia. we're dropping the heart rate, so we don't want to drop it too low. We're watching for hypotension. Any of these medicines that we're giving for hypertension can have a hypotensive result. So I don't say it 100 times. Just know that you're going to watch for dropping it too low. So think about all those things that go along with hypotension. What happens if you've got a patient that's hypotensive? Huh? They may be lethargic. What else? They have a risk for falls. Okay. So risk for injury is an issue here. Orthostatic hypotension. So, see, you know that. You're building. Here we go. Good. Your patient may be weak. They may be fatigued. And sometimes patients on beta blockers have a depression as a result of that. Now, one thing I want you to remember, patients on beta blockers can block some of the response to the sympathetic nervous system. Okay? So, in effect, it can suppress the signs of hypoglycemia in your diabetic patients. Okay. It can suppress some of the effects of the sympathetic nervous system, so it can block or kind of hide the effects of your patient when they're hypoglycemic. Okay, so you have to be very careful with your patients who have hypoglycemia when you put them on a beta blocker. They may not have those usual signs and symptoms. Okay, they'll have the sweatiness, the diaphoresis, but they may not have the lethargy, the weakness, things like that. Okay, so it suppresses. Beta blockers can suppress the signs and symptoms of hypoglycemia. Beta blockers will suppress the signs and symptoms of hypoglycemia. If anybody misses that one, I'm subtracting 4 points. Okay? Okay? That's a big deal because you're going to have patients that lots of folks, we give beta blockers for lots of things. Lots of things. I'm sure you have heard the beta blocker term a lot of times already, right? So you're going to have patients out there who have diabetes. We've got them on beta blockers. Okay, so you need to know that. You need to be looking for that. Okay. Calcium channel blockers or calcium antagonists. They actually, remember, calcium has something to do with the strength of muscular contraction, right? As it moves in and out of that cell and all that business that you learn. So when we block that, what we actually do is relax the muscle a little bit. It relaxes smooth muscle. This is like cardizem, Norvasc. Those are going to be your main ones that you see out there. Those are kind of your usuals, okay? But what they also do, they decrease the heart rate, they decrease the force of contraction, and they actually dilate peripheral vessels. So your calcium channel blockers are going to be most effective in your older patients, and they're really effective in African Americans for some reason. So when we dilate peripheral vessels, what do we see? What does your patient do? They have flushing. We have to watch for flushing, dizziness, again, hypotension, because you are for sure dilating vessels now. Okay, bradycardia. So you have to watch for cardiac changes too, because remember, you're messing with that stuff that affects muscle. So watch for cardiac changes, and you also watch for worsening congestive heart failure. Your ACE inhibitors, they block angiotensin. Remember, the kidneys get called upon, they release renin. Renin stimulates angiotensin, okay, to work on the blood pressure. This actually inhibits that, because what is angiotensin? The vasoconstrictor, right? So the ACE inhibitors block that. This is your prils, P-R-I-L-S, captopril, lisinopril. These are used really commonly with your diuretics. We want to watch for dizziness, headache, because they prevent vasoconstriction, right? So they may have headaches. They may have edema. And ACE inhibitors tend to cause a cough in patients. And it's an irritating, hacking cough. And it gets to the point that they actually stop the medication. Now, ACE inhibitors are less effective in African Americans. Your ARBs prevent the release of aldosterone. What does aldosterone do? Causes you to retain fluid, right? Retain sodium and water. So it prevents that release of aldosterone. So it prevents vasoconstriction, and it helps to decrease blood volume. Yes, because it prevents retention. What have you heard? What other kind of conditions have you heard these medications being discussed with? CHF. Okay, so these things are commonly given to treat CHF as well. Some renal issues, especially when you have fluid retention, may be addressed with some of these medications too. Okay. Now, your ARBs usually end with TAN, T-A-N. Losartan or valsartan. Got to watch for dizziness with this one. Okay. Your central adrenergic blockers inhibit the impulses from the vasomotor systems, or vasomotor center. This is like your catapress, Aldamet, So it's working centrally with the central vasomotor center. I cannot say that today. Center. It blocks that response, okay, prevents that catecholamine release, the nervous system. But it works at the central nervous system. So your side effects are sedation, impotence, and you can really get into some orthostatic hypotension with these. Because again, they're working centrally, so it's a more broad kind of response with your side effects. Catapress, Aldamet, I'm losing y'all quick, I know, I'm sorry. I wish there was a way to sing and dance through this, but there's really not, I'm sorry. Y'all hate games too, I'm told, so, you said you wanted lecture, by God, you're getting lecture. Okay. Games are good, activities are not. No crafts, okay. 13th grade. Oh, okay, all right. Hang with me a little while longer, I'm sorry. Okay, the alpha adrenergic receptor blockers. This is Cardura and Minipress. Cardura, Cardura. Exactly the way it sounds, yeah. And then Minipress. SS, 2 S's, Minipress, yes. What these do, they block alpha receptor stimulation. So basically, it decreases vasoconstriction of the arterioles. It decreases vasoconstriction of the arterioles. With these, we want to encourage our patients to lie down for a couple of hours after they take a dose that has been increased, or if it's their first dose of the medication. I mean 2. Yes, I mean 2. Couple 2. Yes. 4 is not a couple. A couple is 2. There you go. 4 is a couple in Utah. There you go. Why, yes, it is, Chris. Well, you're wanting it to be you've got to be careful because they're really prone to orthostatic hypertension with this drug. So we want them to take it, lay down for a while, let it stabilize out their blood pressure, and then we've got to caution them too to rise slowly, sit a minute before they stand up and all that. Okay. You could have them take it at bedtime. any of these, your patient has a risk of orthostatic hypotension. So we always want to teach them to, to change positions slowly, sit up slowly. Sometimes the dizziness is bad, that they do encourage your patient to take it at night, but if they're already having to get up at night, maybe that's not the best choice for them. Yeah, and you just think about, if it's an elderly fella, he's probably got prostate issues going on too, and maybe he can't hold it. Once he goes, he got to go. So there's no rising slowly and all that business. So, you have to just look at what's best for that patient. You think about somebody who works at night. They're all messed up anyway. So. Okay, and then the last one on the list, thank goodness, is the direct vasodilators. These are the bad boys. These are the big boys that we give they have a direct result of massive vasodilation. Okay, these are the medications that we give when people are at stroke level. Okay, and we'll talk about a couple of these more we'll talk about more when we start talking about emergencies. But this is like your Lonitin, apresoline, nipride. A lot of these are given IV for quick reduction of the blood pressure. Lonitin may be given in a very small dose, but the other ones not usually, no. I have seen people on low doses of Lonitin before. And because your patients are at such a risk for stroke, what else might we have them on? Such as? Not necessarily there. What do we start first? Where we start the aspirin. Your patient may be given a low-dose aspirin just as a preventative, okay, or as prophylaxis against stroke. All right. Can I change this slide? Are y'all tired of looking at it? I am. Okay, let's move on. So here's your little schematic about treatment. Okay, it's kind of an algorithm. And I'm sorry, I don't have this separate for you, but you can, it's pretty much what I've just said. Okay? In a nutshell, I could have just showed you this and we could have stayed at the house, huh? Principles of hypertension treatment. We want to treat to get it less than 140/90 or less than 130/80 if they have diabetes or kidney problems. Okay? The majority of your patients will will require 2 medications to reach this goal. We're going to try lifestyle modifications. If that doesn't help, then we're going to move on to our drugs. And it breaks it into stage 1 and stage 2. Stage 1 is just, it's high blood pressure, but it's a little lower levels than stage 2. Okay? But again, we're starting out with the thiazide type diuretics and moving on from there. So we're going to use a more aggressive treatment for stage 2. Excuse me. And what it means by compelling indications means if their medications are, if they've got several other comorbidities going on, something that we need to treat them immediately. Okay. If they're still not at their goal blood pressure, then we're going to play with their meds a little bit, adjust them, maybe have to add one. But if we've started to see blood pressure that has stayed below 140/90 after about a year, then we're going to try to start decreasing some of those medications. You'll hear your patients say they don't want to start on those medications because they never come off of them. That's not true. the majority of them do stay on because they don't try to do those lifestyle modifications and things like that, or they've got vessel damage, et cetera, et cetera. But some people can actually come off of their medications, their blood pressure medications. So when we have a patient who has heart failure, coronary artery disease, or diabetes, we're going to start off with some beta blockers. We're going to do the diuretics, and we're going to start off with beta blockers. Okay. We're going to try our ACEs if they have heart failure, diabetes, if they've had heart damage like an MI, or if they've got kidney disease, we may start them off with ACE inhibitors. So with any of these medicines, we want to watch for hypotension, encourage our patients to move slowly, change position slowly. Safety is an issue. It is not. No. It's on. It'll be on Integrity. I'm sorry. I don't know where I found this.
It's right there.
Yeah. Sorry, I could not find it. Okay. All right. So when we're talking about pharmacologic therapy, the nursing implications are making sure that our patients get their drugs. Remember, that's one of our functions there, right? We're monitoring for effects of those medications, and then we're doing teaching about those drugs. Okay. So keep in mind that your older patients are at greater risk for having complications and side effects from these medicines because they have reduced liver and kidney function. So the meds tend to stay with them a little longer. They respond differently to those drugs. A lot of your patients are taking over-the-counter medications that can contradict the effect of some of your medication, your high blood pressure medications. And then your patients may also be placed on cholesterol and lipid controlling medications. These are usually your statins, okay, your Zocor and, oh Lord, I can't think of another one. What's the other ones? Thank you, Crestor. Thank you. They weren't coming. Crestor, Zocor, Lipitor, thank you. The ORs. Right. And then again, your patients may be put on aspirin. Okay. So I want you to be familiar with the names of some of those drugs I just gave you because you're going to see them a lot. You're going to see them a lot out there and kind of know what we're using them for. Okay? Do what? Use for everything. And what blocks the signs and symptoms of hypoglycemia? Beta blockers. You're going to see that one. I know you're going to see that one. Probably about the 18th. You still use it. You still use it. But you have to just be aware that you have to monitor a little more closely for hypoglycemia. You may have to. And you have to let your patient know, too, because if they're going home on this, that's part of that teaching. Okay? All right. Now, secondary hypertension has a specific known cause. We've been talking about primary that just happens just cause, right? So you also have patients who get hypertension as a result of another process, another disease process. Usual causes that you see is renal disease. When you have renal failure, what happens to the body's fluid volume? You're retaining fluid. So you got more fluid, your blood pressure goes up. Okay? As well as blood flow may be altered or it's not filtered due to the renal damage. So that just potentiates the whole problem. Okay? Retaining even more fluid. You may have endocrine issues like thyroid problems. You may have excess secretion of the adrenal hormones. Okay. What's the one we've talked about today? Aldosterone, right. Remember, it comes from the adrenal medulla cortex is one of them. Okay. Which causes you to retain fluid. It may be narrowing of the aorta. Remember we said that it's not as pliable, especially as you get older, or if you have an actual stricture there in the aorta. The heart's having to work harder. Okay, you're getting some fluid retention, congestive heart failure, blood pressure can go up. You may have neurological problems that lead to high blood pressure. Increased intracranial pressure. Spinal cord injury. That affects the sympathetic nervous system. Depends the level. Depends on the level. But no, you can have increased intracranial pressure and you have damage to that nervous system, so your response is all out of whack. Your BP regulation can get out of whack. Some medications, we talked about some of those. Some oral contraceptives. What else did we say? What other medicines did we talk about? Huh? Amphetamines, right. Cocaine, your oral contraceptives, antihistamines can do it, right. Right. Estrogen can do it. And then, what are you learning about in 106 that causes your blood pressure to go up? And I don't mean kids. I just mean, what else did you learn that causes your blood pressure to go up? Pregnancy. Pregnancy. Kids will do it too, but pregnancy. Okay. Do we need a break? Tiffany says yes. All right. I'm not going to give you.